Hello, everyone. Welcome back to Piers Platypus. Today we'll be talking about acute and chronic renal failure, also known as AKI and CKD. So, an overview of this. So, AKI is a more abrupt short-term decrease in GFR, the glomerular filtration rate, plus an accumulation of nitrogenous waste occurring over days to weeks. So, as opposed to CKD, which is a lot more long-term, I think around 3 months. And it's the end result of progressive kidney damage. AKI has three causes: pre-renal, renal, post-renal. So sort of like your causes of jaundice: pre-hepatic, hepatic, and post-hepatic. We can split it up like this. So in AKI, you basically want to think of what can cause injury to an organ, right? So there's a bunch of different things. One is reduced blood flow. You get less oxygen, buildup of metabolites, less venous drainage, et cetera, and the organ eventually dies. You have infection or inflammation. Drugs and toxins can also cause an organ to get damaged and increase pressure. So then you can classify whether these things happen before, in, or after the kidney. So here's an overview of all the different causes. You probably don't need to know all of these, but you can generally see trends, and we'll talk about them very soon. Okay, so pre-renal causes. Pre-renal is pretty much about blood flow, right? What's before the kidneys or the arteries that are going to the kidneys. And so if there is if there's a rapid decrease in blood flow, also known as shock, that causes hypotension, an organ can die, and that can be any organ. So in circulatory failure, you get hypovolemia, which is volume loss and dehydration. So these are three different types of shock. So one is hypovolemia, where it's like you don't have enough volume. You can pump as much as you want, but there isn't enough blood to go around. The second is cardiogenic shock, which is the actual pump has failed. So you might have enough blood to go around, but like in a setting of an AMI, your heart loses the ability to contract as efficiently. And the last one is septic shock, which is sepsis is infection of the bloodstream. So when bacteria or viruses enter the bloodstream and cause infection systemically, and what that causes is severe vasodilation because of the endotoxins that the bacteria release. Another one is renal artery stenosis. So even if you're not in shock, if the vessels, the renal arteries, get stenose severely, there's reduced flow and thus reduced perfusion, which can also cause AKI. All right. Intra-renal causes of AKI. So there's a lot of different intra-renal causes, but they're not focused on as much in year 2. But you think of the different components of the kidney and see what can go wrong in each of them. So you have the tubules and the interstitium, and what can go wrong there is acute tubular necrosis, and that is essentially death of the tubules, death of the tissue of the tubules. And that can be either ischemic or it can be toxic. Then you have the glomeruli in the nephron, and you can get glomerulonephritis, which is pretty much infection and inflammation of the actual glomeruli, categorized by nephrotic and nephritic syndromes. And then you've also got blood vessels within the kidneys, and within the kidneys you can have hypertension or you can have a clot, which would all cause damage to the actual kidneys. Lastly, post-renal. So what's after the kidneys? The only thing after the kidneys are the ureters leading out, and then they go into the bladder. They're both filled with fluid. And so if anything was to obstruct either the bladder or the ureters, the fluid behind that obstruction will build up. As that fluid builds up, the pressure increases because it's a very limited space, and that causes damage to the actual kidney parenchyma. So all you need to think about here is what can obstruct the ureters or the bladder. You can have strictures, stones, clots. Your prostate, which gets enlarged in BPH, can cause bladder outflow obstruction. If the bladder outflow is obstructed, the urine doesn't have anywhere to go, and so it'll build up behind, so it'll cause hydronephrosis. And then you can have a congenital pelvic ureteric junction obstruction. Yeah, so pretty much just anything that can cause obstruction post the kidneys will cause damage. All right, moving on, CKD. Pretty much the end stage of an AKI. So if the characterizations of an AKI continue for more than 3 months, it becomes a chronic issue. And most commonly, this is caused by hypertension and diabetes, right? The most important thing you need to know about it are how it clinically presents, because the kidneys do a lot of things. And so when they're damaged, a lot of things go wrong, and that's what causes your clinical symptoms. First of all, the definition: CKD is a GFR less than 60 mils a minute. Either that or albuminuria or hematuria, so albumin or blood in the urine, or pathologic abnormalities on biopsy. So if you take a biopsy of the kidney, you see things wrong, and all these, if either of these continue for more than 3 months, that is characterized as chronic, and thus it's CKD. Okay, so we talked about hypertension and diabetes being the leading causes of it. Let's talk about how they cause the damage to the kidneys. So in hypertension, you have all the high pressure and your blood vessel walls thicken, which causes narrowing of the lumen, right? When the lumen narrows, as we talked about in AKI with renal artery stenosis, there's decreased perfusion of the nephrons. So if there's less blood going into the kidneys, your GFR goes down, because your GFR is determined by your blood flow. And if your GFR goes down, we all know the response to that is an increase in renin production, which activates the RAS system, the renin-angiotensin-aldosterone system. As that RAS system gets activated, all that sympathetic stimulation happens, and there's an increase in heart rate and even more hypertension. More hypertension, more narrowing of the lumen, decreased GFR, increased renin production, and so on. So it's a really horrible cycle to be stuck in. Eventually, this leads to glomerulosclerosis, which is thickening and hardening within the Bowman's capsule, and thus, and then ischemic injury and loss of the nephron itself. In diabetes, the high blood glucose leads to overproduction of your ROS, and which then causes production of growth factors. And you'll talk a lot about this in the endocrine system, but there are these 4 structural changes that happen, not important at all whatsoever at a year 2 level. And then also glomerulonephritis and PCKD and other kidney diseases can also cause CKD. Okay, I talked about how the functions of the kidney, we have a lot of them. And so if you use them to determine the complications of damage to the kidney, it'll make it a lot easier, right? You have acid-base balance, which is done by the kidney, that leads to metabolic acidosis if the kidney can't do that anymore. There's water balance. If your kidney can't do that anymore, there's fluid retention, there's edema. Where can you get edema? You can get edema in your ankles, ankle edema, or you can get edema in your lungs, pulmonary edema. Your kidneys also help balance electrolytes. And so if that's damaged, there's disturbances, and the high potassium especially, you really want to look out for that because it can be really bad for the heart. Toxin removal. If that doesn't happen, you get waste product retention and uremia, or an excess of urea in the body is what presents clinically. Blood pressure control, hypertension, EPO production. So EPO is your precursor for red blood cells. If that gets damaged, you get anemia, and vitamin D activation, as we all know, leads to bone disease. And this is just an overview chart of all the different complications of CKD based on the kidney functions. So if you use your complications to guide the symptoms that they'll present with, right? So with water retention, there's decreased, remember, a waterfall of sodium. And so there's decreased sodium excretion and decreased water excretion. That buildup in water causes hypertension and edema. This is pretty much what we talked about before, just presented a little differently. What I'll focus on is uremia. Uremia is a toxin, and when it's usually excreted by the kidneys, and when it builds up, you can have symptoms all over your body. A very buzzwordy is the itch and the yellow uremic tinge, but also you can get hiccups and neuro symptoms, gastro symptoms, etc. So management of CKD has 2 main focuses. So there's you want to slow down the progression of CKD because it's a chronic issue. It's not black and white. It's determined how bad it is by the GFR. And so you want to make sure the GFR doesn't keep dropping. How do you slow progression is your lifestyle modification. So your SNAP-W, smoking, nutrition, alcohol, physical activity, and weight loss. You also want to control their blood pressure. You can use any of your antihypertensives for that, most commonly ACE inhibitors and ARBs, and also glycemic control if they are diabetic, and you can use all the range of diabetic medications there. Treating complications is not really your too competent, so I'll just give some examples of that. So like for the water buildup, you want to give loop diuretics and fluid restrict them, so you get rid of all the water and don't put in as much. For anemia, you can give the EPO injections if it's quite severe, or give iron supplementation. For acid-base disorders, you can supplement with sodium bicarb if it's really quite bad. And for vitamin D, you can give a calcitrol supplement. And finally, in end-stage renal disease, where the GFR gets really, really low, you only really have two options. You either put them on dialysis or you go for a renal transplant. And that's about all I've got for you today for AKI and CKD. I'll see you guys next week.